3, 2, 1.
Good afternoon. I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute. I'm here with my team in the operating room getting ready to perform our last surgery. Our patient has back pain and right leg pain. And this is Dr. Deuk. We're going to get started, okay? Just lay still, don't move, and that's the best way you can help us. If you're having any pain, say ouch, and I will give you more numbing medicine, all right? Deal? Yeah, don't move though. Just say ouch and I'll give you more numbing medicine. All right, I'm feeling around. I'm just checking for the right spot to give you some numbing medicine. You'll feel a little stick and burn. That's normal. Yeah. Well, I apologize, but we're giving you a little numbing medicine. Just relax. Anything you can do about that? Yeah. So, we haven't even started yet. Okay? You're doing good. We're just giving you numbing medicine. Is that better? Yeah. All right, I'm just going to do it quick so we get it over with. Hang in there. All right. You're good, you're good. I'm done. All right, lay still. If you move around a lot, it's going to change where the x-ray sees you. Okay? All right, so I don't know if he's still symmetric on the table. Let's see what we've got here. Can we turn the lights down? So our patient has two damaged discs. One is L4-5, the other is L5-S1. Shot? And I'm going to go in and repair both of them today. These discs are described as, herniated, degenerated shot. And different radiologists will describe them different ways. But in the end, shot, it doesn't matter because they're all the same thing. They all start with a tear. Shot? Much better, Dr. Berndes. Shot. All right, so I need to create a new trajectory. Shot. Shot. Well, at least the trajectory is a little better. I think I'm on a shot. Let's get an AP and see where we are. We need to make sure we're not hitting the iliac crest with the needle. So our patient is suffering with back pain and right leg symptoms. The symptoms in the leg can be pain down the leg, weakness in the leg, numbness in the leg, or tingling in the leg. All right, we're good. We just need to be a little more lateral. So the symptoms of weakness, numbness, and tingling are called radiculopathy. And every patient we operate on has different symptoms. So some of them have just back pain. Some of them have radiculopathy. Shot? Shot? Some of them have sciatica. Shot? All right, so shot, I do need him awake at this point. So let's get an AP. So go ahead and let him wake up. But I like that. He's sound asleep. He's loving it. You made him very happy. And for those of you watching, including our patient, everybody has a different pain tolerance. So when I go to the dentist and they're going to stick that needle in my mouth and numb up my teeth, it's like, oh God, not this again. And it hurts, right? So even numbing up things hurts, just doing the numbing. But in the end, our goal is to make him comfortable so that we can do his surgery with minimal pain. All right, I'm pretty happy with this so far. How much longer do you think? Can you line up those pedicles a little better? Just try to wag maybe a degree and let's see if that improves it. So it's not bad, but I think we might be able to do that's maybe a little better. What do you think? I don't know. I'm on the fence. Maybe we go back. It's hard to tell because he's got a lot of soft tissue that obscures the view. What do you think? So maybe go back. Yeah. Yeah. But I definitely want him awake for this part. All right. Shot. So it's not bad at all. Shot.
Okay, Tim's with us.
You awake?
Tim, say yes or no. Are you awake? He said yes.
Are you awake? Can you hear me? How was your sleep? Was it good? You realize you were sleeping. You were sleeping pretty good. Are you having any pain?
Tim, you having any pain? Where's your pain? Back.
All right, but not down your leg. Shot? Shot? Yeah. Not down your leg, right?
He said no. Back.
Shot. Give me an AP. So we are accessing, for lack of a better term, the L5-S1 disc herniation on the right side through what's called a transforaminal approach. And honestly, it looks really good because you can see the pedicle of 5 and the pedicle of S1, and we're really between them. And it's not the top to bottom between them I'm looking for. It's, you know, the line that you would draw between the pedicles in the center of the pedicle down. And that's really where we need to be. Are you okay?
You okay?
All right, lay still. Where do you feel that?
Back or leg?
Where do you feel that?
Back. He said back.
Mm-hmm. Just the back. Shot? All right.
Stay still. Stay still, buddy. Sensitive right there, yeah.
Shot? All right, so we're hitting the end plate, I think. I think I want to go a little bit lower. Just relax, you're doing great. Shot? 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 Where do you feel it?
Back or leg? Back.
Huh. I mean, we could be right up against that end plate. That's what I'm feeling. Shot. Interesting. Very interesting. Let's see, I'll try one more time with this trajectory. I may have to change my trajectory yet again. Shot. So I need to be a little bit like lower. We call it caudal, towards the bottom, towards the feet. Shot. I'm trying to hook along the soft tissues of the facet. That's better. Where do you feel it?
Back or leg? Leg.
How far down your leg? How far down your leg? I couldn't hear him.
Halfway.
Not to your foot. That's just the facet. Shot. Shot. That should be it. Where do you feel it? Ask him where he feels it, please.
Where you feeling it?
Back or leg?
Back or leg?
How far down your leg?
How far down?
You don't think we're off?
It went to waist and then it moved down to where? All the way down?
No, where in your leg? On your, past your knee or not past your knee? I can't.
Above the knee. Side of his leg
Yeah.
above his knee.
You know what's weird is that 5 doesn't look right, Monica. Let's try some different orbital shots. The WAG I think is okay, but the orbit doesn't look right to me. That looks better. A little more. That looks maybe. I'm not sure it's worse, is it? All right, let's go back then a little bit. I'm not disagreeing. Yeah, because you're not really parallel to him, where orbit is actually changing the WAG. All right, is it still down?
Yeah.
How far down? How far down your leg?
It actually feels really good. Just
Feels good.
can get out from the fried chicken stuff.
Huh?
We can fried chicken stuff.
What'd you say?
Oh, fried chicken.
Fried chicken?
Fried chicken.
All right, I'm asking you about your.
You know what? I was gonna say, I don't think we got fluent speech.
When your leg. Yeah. All right, so,
I think we got gibberish.
okay, so where's it going down your legs?
But it's not gibberish, it's actually giblets. Because it's fried chicken.
Okay.
Yeah, we're not gonna do it again. We're where we need to be.
Okay.
Yeah, so you're good. And we're where we need to be. So at this point, let me know if it's bothering you. We're gonna have you awake for just a few more minutes, about 5 minutes, and we'll be done, okay? Then we'll put you to sleep.
You're doing great.
Yeah, you're doing really good. And you're very helpful, by the way. Thank you. I ought to put you on the payroll.
That'll be fine.
You said that.
All right, Sean. Let's have some num-num. So, it'd be a nice little exercise to discuss what are the pain-sensitive structures as we pass from the skin down. And they are the skin, the fascia, the periosteum. Muscles can be a little pain sensitive too, but generally not so much. And then of course the disc. Sean? Is that where I am right now? Good. So, blood pressure is good. Yeah, that's your facet joint. I'm going to sneak around it. There we go, Sean. You're fine. That's just your arthritic facet joint. Sean? Yep, perfect. Sean? Almost done. Are you okay?
Yeah.
All right. Boy, I feel a herniation there. Sean?
Are you talking to me or them? Or mine is them?
Where do you feel that?
What are you feeling?
Oh, yeah, yeah.
Back
Where?
leg.
Back.
No. You're okay.
Sorry.
You're okay.
You're
Yeah.
doing great, buddy.
You're doing everything we expect you to do.
You're answering all the questions.
Yeah. You better now?
Yeah.
So your discs are definitely painful on the surface. Yeah, I could see that. You all right? What are you doing there? Hiccuping?
I can feel it.
Yeah, I bet you can. Just relax, all right? No, what? What are you doing? How bad is that on a scale of 1 to 10?
7.5.
No, what's the highest it goes? 10? How high? What's the highest it went? Oh my. Just give me a number.
9. You're saying 9.
All right, perfect. So is that where you typically get back pain? All right, all right. You're doing good. We just tested your L4-5 and it's causing your back pain. 9 out of 10, 4-5 concordant. So I'll do my little drawing. Your elevated blood pressure is making me look bad here. All right, our patient has 2 herniated discs. One is at L4-5 with annular tears, and the other one is L5-S1. And the tears are here on the right side. That's why it's affecting the nerve roots going down the leg. I just tested this one, and it was a 9/10. Concordant, meaning that's his typical pain that he gets every day. Sorry about the blood. That's Dr. Berndes' fault. Right? Hey, if you cut a blood vessel and there's no blood pressure, you won't get any bleeding, will you? It's not my fault. It's your fault for having so much blood pressure. You like that? That's how neurosurgeons see the world. It's never my fault. You comfortable? All right. How bad is that on a scale of 1 to 10? Huh?
9. You just said 9.
He can't say 10, can he, huh? All right. We're done. We're going to put you to sleep. I apologize. We needed to test the discs. They're both causing a 9 out of 10 pain. Is that where you typically get your back pain? All right. You get to go to sleep. When you wake up, that pain will be gone the rest of your life. Congratulations. Give me a count from 1 to 100 out loud. Nice and loud. All right. So it might seem to some of you as cruel and unusual punishment by a sadist. You would be right as long as you're talking about Dr. Berndes. But in all seriousness, we do a discogram to confirm that indeed we found the source of the patient's pain. After all, they're having surgery on a disc that I believe is the cause of their pain from the annular tear in the back of the disc, the posterior annular tear, and I want to confirm that it is. So that's what we just did. I pressurized the disc, and sure enough, it caused a 9 out of 10 pain. Now, if that disc was not the cause of his back pain, he wouldn't have any pain at all. So we just literally did a evocative or confirmatory provocative discogram, and we reproduced his pain that he gets every day in his back. So that's a very good sign. And that means that he's going to do really well with the surgery. He's asleep now, and he needs to be because this part's more stimulating. We like to say the word stimulating, but what we're really saying is more painful. I just want you to note the patriotism here. Red, white, and blue. I'll leave that there for a little while. Now, if I told you there's an alien baby inside, some of you might believe me. Right, Monica? After all, there are people that believe we did not go to the moon, and there are people that believe the earth is flat. I encounter some of these people on Facebook from time to time. They're my favorite people. Right? I showed you one of those Facebook posts. The woman said, I just had surgery 2 days ago, and I can't breathe. I have so much pain in my abdomen. And one of the viewers said, or one of the Facebook people said, oh, just take, what was it? Yeah, a mint julep or something. Drink 2 mint juleps a day, and you'll be fine. So that's the kind of great medical advice you get. You know, you have an acute abdomen, person's dying from peritonitis, and what they get on Facebook is, oh, just have 2 mint juleps a day, and you'll be fine. That's the kind of medical advice you can get on Facebook. All right, so patriotism aside, we are now inside the L5-S1 disc. We're going to do the entire surgery through this little tube. And for $9.99, you could have one of these tubes yourself at your house. You could do whatever spine surgery you want. Open up a neurosurgery center in your garage. But in all seriousness, they're not $9.99. They're more like $999. Okay. I'm now going to advance this tube into the disc through the tear that we're here to repair. You like that? through the tear that we're here to repair. Shot? I'm advancing that tube into the disc. Let's see what we got. One more shot. It looks like the tube is just entering the disc now. Shot? People don't like when I hammer on the spine, but it's not possible to do the surgery without it. I tried using my foot once, but it didn't work out too well. All right. We still offer you all the ability to ask questions. So feel free to type up a question for Dr. Deuk Majan or my team. Shot? I'll do my best to answer it for you.
Doc, I got a question from YouTube.
Yes. Shot?
What can you do about a disc with degeneration that has lost the majority of the NP?
Yeah, what can we do about a disc that's degenerated and lost the majority of the nucleus pulposus? We can fix it the same way we fix everybody else's. So if your disc has lost the majority of the nucleus pulposus and you have pain, then we can fix it. If you have no symptoms at all, then I would not recommend fixing it, because there's no reason to do surgery if you don't have any symptoms. So for anybody that has a degenerated disc that's lost the nucleus pulposus, it doesn't matter how much nucleus pulposus you lose, we can repair the disc and take away the back pain that came from the disc. We can also unpinch nerves, so we can treat spinal stenosis. So this surgery treats back pain and spinal stenosis with radiculopathy. And that's what we're going to do for this gentleman, and we can do that for anybody. You don't need the nucleus pulposus in your disc. I have seen thousands upon thousands of patients with no nucleus pulposus and totally degenerated discs that have no symptoms whatsoever. We don't treat them. We don't do anything to them. We leave them alone, okay, because they're asymptomatic. Interesting. All right, we're ready. So we're going to bring our scope in. How many of you have seen this scope? We show it to you most of the time, but I'll just go over the details. This is the endoscope we use. It's a long, hollow tube that allows me to put the laser through one end and come out the other. And I can actually see what I'm doing at the end because there's a little lens there. It's attached to a camera system that then projects the image from the camera up onto the monitor. There's a light source, which is the blue cable, and there's a source of irrigation, which cleanses everything out. All right, let's get started. We are inside the L5-S1 disc right there. Beautiful. You can see the blue dye, which stains the degenerated nucleus pulposus that you were talking about a minute ago.
Doc, I got a question from Jacob from YouTube.
Hi, Jacob.
Have you treated very many patients with ankylosing spondylitis?
Yeah, no problem. Yes, thank you, Chet.
Sorry.
No, you did a great job, Chet. You did a great job. And first of all, I'd like to just recognize Chet's efforts. Chet is actually the head of IT, and he has stepped up to take over the broadcasting job that was given to him at a moment's notice. So thank you for doing that. Ankylosing spondylitis is an inflammatory condition of the spine where basically such severe arthritis causes the discs and facet joints to fuse together. And we call it the bamboo spine, but really all it means is there's autofusion happening. So have I treated patients with ankylosing spondylitis? Yes. And what exactly have I done? Well, the laser surgery doesn't take away ankylosing spondylitis, as you can imagine. What I do is that If somebody with ankylosing spondylitis has a painful disc herniation, a bulging disc, a ruptured disc, or a degenerated disc, I can go in with the laser, thank you, and I can actually repair their disc and take away their pain from that disc. So that's about all I can do. Now, the other thing that happens to people with ankylosing spondylitis is they can fracture their spine right where it's fused. And typically what they'll come in saying is, I have a lot of pain, I fell, or I had an accident, and now I can actually move my spine more than I used to. So they actually report increased movement of their spine compared to before the accident. So they have now more movement because they actually fractured their spine. That's a really bad sign, and it needs to be fused. So I'm not sure what you're hoping for with your ankylosing spondylitis, but I don't have a cure to ankylosing spondylitis. It's a really unfortunate condition because it doesn't have a cure. But someday I think we're going to make progress, and we're going to end up finding a drug treatment that will prevent it from getting worse. You're doing great. So this is the herniated disc, and I pulled out another piece of it just a minute ago. So basically, it turns out that spine pain, pain in the back, pain in the neck, is really caused by two things primarily. One is the disc that's damaged. The other is the facet joints. And if you ask me, based on my experience of treating these two conditions, either discogenic pain, which is pain from a disc, or facetogenic pain, which is pain from a facet joint, which is more common? Definitely discogenic pain is more common. Which one is fixable? They're both fixable. You're doing great. Lay still. I would say that disc pain, pain from a herniated disc, from an annular tear, probably accounts for around 75% of chronic back pain in the lumbar spine. And yeah, probably about 80-85% in the cervical spine. So people suffering with neck pain or back pain, there's a way to treat it effectively to get rid of it, and it involves treating the disc or treating the facets or both. Now, one treatment that fixes both is fusion. Spinal fusion done properly will fuse the facets and the disc. So if you have a painful disc or you have a painful facet, you can get both of them treated with one procedure called spinal fusion. Is spinal fusion necessary to treat them? No. Are there better treatments besides fusion? Absolutely. That's what we're doing right now. Deuk laser disc repair. Far better than fusion. Why? Fusion is highly invasive, dangerous, causes scar tissue, long recovery, and so many complications from fusion. Pneumonia, heart attack, stroke, death, nerve damage, spinal fluid leak, failed fusion, infection, bleeding, vascular injury. The list goes on and on and on. And the chance of having complication with spinal fusion is around 20%. Okay? Deuk laser disc repair, very safe, small incision, immediate recovery, literally immediate recovery. You get to go home after surgery 1 hour after your surgery. All the patients we did today so far are already gone home, except for this patient. And we don't want him going home until we're done. All right, what questions can we answer from our audience, Chet?
Jacob again from YouTube. Which is better for nerve pain, gabapentin or Lyrica?
Great question. Which is better for nerve pain, gabapentin or Lyrica? They're both bad. I wouldn't use either one if it was me. Get your nerve pain fixed if you can with surgery, proper surgery. Now, if you told me I can't get surgery, it's impossible. I can't come to Deuk Spine to get surgery, and you had to choose between one or the other. They're both effective in certain people, and they're both not effective. So they both have side effects. You know, the newer drug is Lyrica, and it has had some good success. I think what you'd have to do is talk to your doctor and try one and see if it's effective. Now, these drugs take time to build up in your system and become effective. So you're going to have to give it probably a week or two to really see if it works. Now, you can't stop either of these drugs suddenly, because stopping Neurontin, which is gabapentin, or stopping Lyrica, which is pregabalin, either of them stopping suddenly can cause seizures to happen. You don't want seizures. If you have a seizure, you could die. Plus, you could get pneumonia or asphyxiate yourself, or worse, you could even not be able to drive anymore, right? Once you have a seizure in the state of Florida, you have to wait 6 months before you can drive a car. So people who have seizures, they should get a lot of empathy from you, because their lives are ruined by seizures. They can't work, they can't drive, they can't do anything because their seizure could happen at any time. Anyway, with Neurontin and Lyrica, though, your seizure will happen as you withdraw from the drug. So make sure you taper off of it slowly. As far as other side effects, they're pretty bad. That's why I don't recommend drugs. There is another medication, if you're so inclined, that a lot of people don't know about that really actually helps quite a bit. But it may make you sleepy, and it's called Amitriptyline. Amitriptyline can help with leg pain from nerve pain, and it can help with back pain as well. It'll help you sleep better, and it may actually make you feel better. Amitriptyline is a good one, and it has, I think, less side effects, and it's less dangerous. But, you know, again, I believe in fixing problems, not covering them up with medication. So you're really asking the wrong person.
Doc, I got another question from Whiteside91 from YouTube.
Yeah, let me just say one more thing about the drugs for nerve pain. I've heard of patients having success with something called turmeric. Most of you have heard of it, but turmeric is basically an herb. Yeah, I know. I'm sorry about that, buddy. We're right in the most painful part of your disc. Just about done. Woke him right up. We're in the... No, that's fine. I'm just telling everybody he was sleeping beautifully until I got right to the back of the disc there, where the most concentration of pain fibers are, you know? So I knew he wouldn't be happy about that. But what I was going to say is turmeric can actually help with nerve pain. It's natural. So something to consider. All right, sorry. Go ahead with the next question.
From YouTube, I wonder if any of your patients have gone back and watched the live stream of their surgery.
Yeah. So the question is, hey, he's coming. I wonder if any of your patients have gone back and watched their surgery. They all do, 100%, because we don't just have them go to the live stream. We actually give every patient a copy of their surgery. Yeah. Yeah, I'm pretty much done here. Yeah, he's not happy about that. All right, well, we're done. We're done. Take that. Yeah, our patients are given a copy of their surgery the next day when they come visit me in clinic for a checkup. And the reason that we do it the next day is that my team just has to, you know, make copies. Can we turn off the scope? But everybody gets a copy of their surgery as long as we recorded it. Now, unfortunately, right now, our videographer left. So he went and took a better paying job. That said, we don't have a videographer anymore. And that's why I'm so appreciative of Flynn and Chat covering the videos. So, but you may see that the videos are different. The live stream may be a little different than it's been until we can hire a new videographer. So if you know somebody out there that wants to have a videographer job that does video editing or graphics, yeah, come on in. Let me know. We've got a job opening here. So Flynn, you're supposed to clean the center of this with the guide wire.
Okay.
You understand? When I give it back to you? All right, very good. We're finished with, you need to be helping me here. Take that. We're finished, I need the roll. With L4, what was it, L5-S1? Now we're gonna do L4-5. I don't need the roll so wide. I like it more concentrated. All right, tube is coming out. Fluid adapter is not engaging. Great questions from our audience, by the way. Feel free to ask more.
Got another question,
Guide wire.
Doc,
Yes.
from Monica from YouTube.
Hi, Monica.
Hi, Dr. Deuk. We met last Friday on Zoom. My
Great.
chiropractor said 50% of his patients
Sure.
come back to him after laser. I told him they probably do because we don't have good doctors in MN.
I kind of barely heard the question, but somebody said, my chiropractor told me 50% of the patients come back to him or her for chiropractic after laser. So I don't know what laser you're talking about, but it's definitely not my laser. And number one, there's a lot of scam lasers out there. Yeah, you got way too much at the top there, and we need to see better at 4-5. So there's laser treatment where they're actually putting lasers on your skin, and that stuff doesn't work. I wouldn't do it. And then there's Deuk laser disc repair. My patients go to therapy after surgery, so it's expected that they would go back to the chiropractor. All right, Monica, can you see the problem? Where's the disc we're treating? Where do you want it to be? Off the screen or in the middle? Good. Can we do that? Sometime this year? Okay, so what are you going to need to do there? You're hitting this side. You're in too close here. All right. Let's get a shot. There we go. Now that's more like it. I'm happy with that. It's still a little too much hip. Shot. Good. It's better. You're actually holding the button too long. I don't know if you realize that, but you keep doing it over and over again. So what happens when you hold the button too long? Shot? Why does it get blurry? Do you even know? Why? What? That's exactly why. Because you're actually recording a movie instead of a photo. And movies don't like moving. The camera can't move because you get a blurry picture. So hold the button shorter period of time and you won't have that. Okay, shot. All right. But not so short that you don't register an image. Shot. Okay. Did I answer your last question? That would be a shot if I'm looking up there. Again, you're holding cine You want to let go of that shot? All right. Yep.
Doc,
Sean?
Monica has another question.
Yep.
Besides the nerve pain in the neck, once the laser is done by you, will I be able to turn my head, chin up, down? On a cervical laser you performed, you stated you were eliminating the, the nerve pain
Shot.
and will not be able to give clients head rotation, which concerns me. I only have 5
Come on,
to 10
Monica.
degrees side to side, up and down with chin.
All right, I don't understand the question. Is this person saying, I can't move my head at all now, and will your laser surgery give me my movement back to normal?
She states she only has 5 to 10 degrees side to side, up and down.
Yeah. No, the laser, there's no surgery in the world that's going to give you back your movement. Except for the laser surgery is the only one that might. Because if your movement is limited by pain, and the pain's from the disc, then it will help. If the movement is limited by your facet joints, then you need your facet joints treated. So there's no doctor in the world that can listen to a question on the internet like that and be able to tell you. We have to examine you, we have to see your MRI, and then we can tell what's causing your restricted movement. So I would say there's nobody that can help you get that done at all, the way you're describing it. Shot?
Got a question from Tom
Sean?
from YouTube.
Uh-huh.
Why do patients scream from time to time? Aren't they under anesthesia?
They're supposed to be. I agree. They shouldn't be screaming from time to time, but we're doing the best we can. That is not. The patients don't have a tube, so we rely on our anesthesiologist to keep them comfortable, and he's doing the best he can do. So there's going to be times when they're feeling pain. Huh? No, we're good. You can move out. The only reason why you're not used to seeing that is because you're not used to seeing what's MAC anesthesia. But if you do MAC anesthesia every day like we do, you see patients who have pain from time to time. The key is that they don't remember it. We don't want them to remember the pain, but people with MAC are going to have pain.
Dynamic operation, there's different levels.
Yeah. So if you're looking and saying, oh my God, they're having pain, that's not right. That's just because you have really no fucking clue what you're talking about. So that's my answer to that. But that's okay. I don't expect everybody to know. That's why we answer questions here. All right, so we are at 4-5. We're going to repair this disc with a laser, and we'll be done. I got about 10 minutes, doctor. So the anesthesia we give is sedation, and it has to be titrated. We give a little more when the patient needs a little more. We give a little less when he needs a little less. And everybody takes a different amount. It's not one size feeds all. So it's all about, monitoring the patient and looking at their heart rate, their breathing, their end-tidal CO2, their movement. So there's a lot that goes on. But when you see a patient groaning or moving, it doesn't mean they're consciously aware of the pain. There's a lot of reflexive movements the human body makes. Think about it. If somebody pinches your toe while you're sleeping, you may not be consciously aware of it, but you may pull your leg will pull back. Okay? We call those reflex movements, and human beings have a lot of reflex movements. reflex movements are really designed to protect us from the environment, from a bad environmental experience. So when we stimulate the patient and create a sensation they don't like, they're going to do what's called primitive reflex movements. And that includes grunting and groaning, moving away from the stimulus if it's noxious. And that's what everybody does. That's normal. So that's why I say, if you don't watch a lot of these surgeries, you would be, thinking there's something wrong, but there's nothing wrong. It's normal. This is a lot of scar tissue here in this disc. So we just tapped the mother lode of dye right there. That's why it's gotten blue and blurry. That's just dye from the discogram stuck in the middle of the disc that's being released. All right, any more questions?
Yes, from YouTube, CC. What does it mean if a CAT scan shows spondylosis grade 1 at the same level I had fused and the 2 levels above it?
Can you spell it? Is it spondylolisthesis or spondylosis? Spondylolisthesis. Is that correct?
Correct.
So spondylolisthesis basically is when two bones in your spine are out of alignment. So usually a slippage, either forward, backwards, or to the side. Slippage forward of one bone on the other is anterolisthesis, or anterior is forward. Retrolisthesis is a slippage backwards, and lateral listhesis is a slippage to the side. You get lateral listhesis when you have scoliosis. You have anterolisthesis, is probably the most common, where the top bone slips forward on the bottom bone. Anyway, the fact that you still have it is normal. People think when they have a fusion surgery that they're going to get rid of their listhesis, but the surgeon doesn't get rid of the listhesis. They just fuse the bones together, so there's no more listhesis. So if you've got a slippage of, say, 10 millimeters to begin with during surgery, you're going to end up with a 10 millimeter slippage after surgery, because we don't, we're not able to what's called reduce the slip or bring the bones back into normal alignment. And we don't have to. As long as you do the rest of the surgery properly, the patient's pain will go away in their back and their legs. So what you're seeing on your report is that you still have a spondylolisthesis. But at this point, if they fused it, it's not going to get worse. And it's not the spondylolisthesis that causes your pain. As I've said many times before, it's the annular tear in the back of the disc that's the cause of the pain. You didn't need the fusion done, basically. But now that you've had it done, your surgeon basically did not put your bones back in alignment. So I could tell you if it was me doing your surgery, I could get rid of the pain, but I would not put your bones back in alignment either. And the reason is simple. I would give it a little bit of improvement, but the harder you pull on the screws to realign the bones, the weaker the screws become in the bone. And you don't want loose screws. So surgeons should not pull on the screws too hard to try to realign the bones. It doesn't do anything for the patient that's positive in terms of pain control or decompression of the nerve roots. And the only thing it does is make your x-ray look better. But then your x-ray is going to look worse when your loose screws cause a failed fusion. So I wouldn't judge your surgeon's work based on the fact that you still have a spondylolisthesis. I would judge your surgeon's work on whether or not you have pain, whether or not it's gone. If your pain's gone, then don't worry about the listhesis you're seeing, because it's not going to do anything. It's just going to stay there the rest of your life. That would be my advice. We need 5 minutes. There's really incredible amount of scar tissue here. I don't know, for those of you who watch me operate all the time, This disc has got tremendous amount of scar tissue, more than I'm used to seeing, and that's because he's had so much inflammation here for a long time. I'm going to try to bring out some of these pieces. So one of my techniques is to grab these little pieces of herniation and free them from the scar tissue that's anchoring them down there within the annular tear. And then they float up because, remember, I'm using irrigation. Irrigation is the constant movement of water. In this case, we're using saline, sterile saline. Same thing we put in IVs. When you go have surgery or when you get rehydrated. All right. So far going good. Doctor, just a few more minutes. I haven't gotten to the outside of the tear yet, but I feel like I'm getting close. Any more questions from our audience?
CC said it's retro.
Retrolisthesis. So if it says L4-5 retrolisthesis, it means the number 4 bone is slipping backwards on the number 5 bone. Retro is backwards, kind of like retro dance parties. You know, they go back and play music from the 80s. Retro is backwards. So retro means backwards. The most common is antero. Listen, either way, if your pain is gone and you're happy, then don't worry about it. You're fine. Okay, there's nothing that needs to be done. But I can tell you right now, I don't know too many surgeons who pull the spine back into alignment, like I said, because it can do more damage than good. So don't let it bother you. I don't think your surgeon did anything wrong with that, just based on what you're telling me. But if you really want me to look at it, I will look at it for you. All you got to do is use the link mri.deukspine.com. By the way, we have the #1 free MRI review link in the world right now on Google. We have the most popular and the most organic, highest ranking on organic search, which is pretty cool. Just about done. So submit your MRI and I'll be happy to look at it and comment on it if you want me to. But only do it if you have symptoms. I don't want to be looking at a bunch of MRIs for people that don't have any pain. Great questions, by the way, today, throughout the whole day, all of you guys out there in Facebook and YouTube. Do we ever get LinkedIn questions, or do you get any LinkedIn today that you know of?
No,
Did
Doc.
you, Flynn?
I do not believe so.
Huh?
I do not believe so.
Are we streaming on LinkedIn? Do you know, Chet, if we're streaming on LinkedIn?
Yes, we are, Doc.
All right. We don't get many Twitter questions either, do we? Maybe now that Elon Musk has 9% ownership in Twitter, we'll get some more Twitter questions, huh? Everybody know that? Elon Musk bought 9% ownership in Twitter for like $2.8 billion yesterday or the day before. I kind of like Elon Musk personally. Huh? He's a cool dude, yeah, he is. At least that's the impression I get. I don't know him personally. He doesn't take crap and he likes to do what's right. That's what the impression, but of course it could just be his publicist doing a really good job. Who knows? I've never met him personally, but personally I think he should open Deuk Spine clinics all around the world and help me fight the insurance companies to get this.
Solar laser.
Huh?
Solar
Solar powered laser? Yeah, there you go, right? The Tesla in space? What about it? Oh, you wonder where it is? Well, space is a big place. I'm sure it's gone. All right. I think we're pretty much done. Let me just look real quick. The nerve is going to be up there. The disc herniation's gone.
Doc, I got a question.
Yeah, let me just clean a little bit more. Yes, I'll take the question.
Monica from YouTube again. So
Hi, Monica.
So do you do laser on the facet nerve pain of the cervical, Dr. Deuk?
Monica, you're awesome. Yes. Do we do laser on the cervical facet? We do. We just did our first one like 3 weeks ago. The very first probably in the world. But yes, we do. We use the laser and the endoscope to do cervical endoscopic laser-assisted rhizotomy. And we did one patient from England, and she was very happy. I hope she's still doing well. I haven't heard anything bad, so it's still kind of early, but I think she's still doing really well. The answer is yes, and I would expect we're going to do more and more, because facet joints are a very common cause of pain, even in the neck, and the laser is wonderful. It's an amazing tool. We're also going to be doing plasma. Plasma is another form of energy, and we're going to be doing plasma rhizotomies soon at Deuk Spine. As a matter of fact, we're teeing up to do them. We're doing our first one this week. All right, laser off. We are done. Great job, my whole team. Everybody did awesome. Thank you so much, everybody, for all the hard work. So after this week, I think I might just give you guys 2 weeks of vacation. No more Dr. Deuk cases for 2 weeks. How does that sound? Paid vacation. You drive a hard bargain, Rita.
I second that.
Right? Well, all right. Thank you. So we're just cleaning this area out with an antiseptic, and we're pretty much done. I'm going to show you the incision so you can all see it. First of all, can you see the tube sticking out right there?
Yes.
Pretty cool, huh? The middle of the spine is right there. So we're coming at about a 45-degree angle, going through a natural hole, just past the facet joint. And the beauty of the surgery is, since we're not doing a traditional microdiscectomy or laminectomy, we're actually not taking away bones and ligaments out of the spine. That means that we're not creating any instability for this patient. Like if you get a microdiscectomy done, that surgeon is going to come here, make a cut, they're going to peel all the muscle and fascia off the spine, and then they're going to have to drill a hole in the bone and take the ligaments and bone out, including the facet joint. Like half of the facet joint they take out. So they're doing all this damage here, creating massive scar tissue and instability just to take the herniated disc out. So we avoided all that by coming from the side. That's why people get this surgery done. It's far less traumatic and a much faster recovery. All right. So I'm just going to apply some pressure for a few minutes until my team's ready to take over. Take your time. All right, any more questions for me? We're going to wrap this surgery up right now. You guys have been great. Chet, I appreciate it. Flynn, awesome job today covering the broadcasting. Okay, any questions?
Yeah, one question from Monica again. That's great. Perhaps I'll be able to turn my head. We'll have to discuss that and the plasma.
Yeah, the reason you're not able to turn your head, so you're asking me to guess why you're not turning your head. So I could tell you the most likely reason is you have cervical facet syndrome. That's the most likely reason. The second most likely reason is herniated disc pain, but there is other reasons. And one of them is, like one of the patients said earlier today, ankylosing spondylitis. If you have ankylosing spondylitis, that means your joints are fusing in your neck, and I can't unfuse them. Nobody in the world can. So, you know, it doesn't matter if we do the rhizotomy or not, you're not going to get movement back because your whole spine is automatically fused. Now, I don't know if you have ankylosing spondylitis. I'd have to look at your CAT scan, maybe your x-ray, your MRI, but I could figure it out. That's why I'm saying it's hard for me to tell you with any degree of certainty if you're going to get movement back. But if it's just due to pain and not autofusion, then we can probably get it back with the rhizotomy, a good rhizotomy, and good therapy, like a chiropractor. We send all of our patients to therapy after surgery, all of them, 100%, because therapy is so important. A lot of times it's chiropractic, sometimes it's physical therapy. I'm going to call the EBL 10 mil. No complications. This was a right L4-5, L5-S1, Deuk laser disc repair. Everybody agree? All right, Chad, thank you. You can go ahead and sign out.
Okay, Doc. 3, 2,